Hello, everyone. Can you hear me like this, or do I need to lean forward? Thank you. Welcome everyone today, and thank you so much for coming and being part of this process and the start of a fantastic journey with us today. To start with, I would like to acknowledge the traditional custodians of the land in which we're meeting here today, and of course pay our respects to both elders past and present, and any Aboriginal or Torres Strait Islander person here today. Welcome, special welcome to everyone, and thank you for coming. And it's beautiful, bright, shiny blue sky outside. It's a nice way to start our journey with Health Pathways. For the first, we're just going to introduce the topic, and then we'll get on to the experts to really talk through and really go into why we're here today. But I thought it was important for us to start with, presenting our overview and how we've come to this journey today. I'm Lynelle Hales. I'm the CEO of Sydney North Health Network, which was one of 31 PHNs across the country. And with me is Andrew Montague, who is the Executive Director Operations at the local health district. Thanks.
Thank you.
All right, let's see if I can get this right. So none of this is new. I just wanted to paint the picture. This is a slide from New South Wales Ministry of Health that basically says this is the journey we're on at the moment if things carry on the way they are. We've got increasing chronic disease in the community. We no longer have an average of one chronic disease per person. It's now an average of 5 chronic disease per person. The comorbidity in the population that we've got has really changed the dynamics of medicine and how we operate. The challenge, of course, is we're almost the victim of our success, which is, probably a bad way to say the element of, we created fantastic technologies in the last 20 years, which is keeping everyone healthy and alive so much longer. But as a result, that means in the community, everyone is actually holding a lot of conditions that they need to live with and that we need to support and manage better in the community. So there really is a shift in the population that surrounds us. And in this area, we've got a significantly ageing population, which is, I think 65% increase over the next 10 years, which is quite an incredible story to really work with and think, all right, we need to start working differently, and how can we do that together? And if you go in the projections of, I don't know if anyone can see that, but on the bottom line it basically says if we keep going with the result of what that works in the current system, it would need up to an extra 110 hospitals across the country, which clearly we're never going to be able to afford as a population. So we're going to need to start working differently. If hospital beds aren't available, how can we work together to actually move forwards?
I think that brings on a very good point from Lynelle in terms of moving the microphone towards me. In terms of, we shouldn't be thinking about hospital beds in this day and age, because there's a lot of care that can be provided out in the community, and it is really appropriate that it can be either in the community or in a patient's home. So we really need to be thinking about where is the best place that we should be treating our patients. In terms of this slide, just to give a bit of a context to Northern Sydney, to highlight on this slide is really just giving a picture around chronic and complex diseases, and that Northern Sydney really does have increased rates compared to the rest of New South Wales. But I think the other things to touch on there is that within Northern Sydney LHD, there's actually 2 different populations. There's the older population that Lynelle talked about, where we have this ageing group that are over 65, but we actually have quite a large group of children and youth as well. And that's demonstrated, for example, at Royal North Shore Hospital, where we see the most presentations to the emergency department outside of the specialty hospitals within New South Wales. So we have this really different cohort. And I think when I'm thinking about chronic disease as well, if we have a look at our mental health, drug and alcohol population as well, there's ever-increasing demands upon the services that we have within Northern Sydney LHD, and there's opportunities there, obviously, with the commissioning that's now coming in with the PHNs, to work a lot more closely together to actually service our population to get good patient outcomes. And really, these slides, just that introduction that demand, it's ever increasing, and really we are placed very well now that there's the one PHN and the one LHD that covers the same population to be able to work together in partnership to actually get some really great outcomes together.
So is this a challenge, or as I think we're all positive and wanting to look at the opportunities that it also creates, so I think we'll go on that context. But basically what it already means instantaneously really, and what we're needing to do as a primary health network and as a LHD is to look at how do we support general practice in the community to deliver in the changed environment that we're looking at and the increased acuity. So as the population is getting sicker and as people are leaving hospital sooner so that they can keep up with the increasing demand, there is going to be a level of increase of acuity or sickness, and needing for support in the community. So we've already started to look at ways of, supporting that, and you've got your hospital in the home program, and we're doing joint chronic disease programs and different initiatives to start to look at how we can support that in the community. Along with that, it's really about starting to look at different ways of working. Could we be providing further specialist support in the community? And in which areas would we focus if we needed to do that? Wow, I mean, that's something that HealthPathways will really help to explore and start to think out, where do we need to focus on, and where are the gaps and where are the priority areas and different elements of our region that we can work together to actually start to support more closely in the community, keeping them out of hospital.
So this slide's really just about we need to start thinking differently, and I think with thinking differently, it doesn't mean that we need to reinvent the wheel. And I think we're very fortunate to be able to learn from the lessons of other health services that have utilised health pathways. And I think, as I said before, now that we have a PHN and LHD across the same geographic area, that real benefit that we can get with health pathways being enabler, I think we're really well placed to be able to do that. Where this sits from a Northern Sydney LHD perspective is that in our current strategic plan, we have priority areas around our clinical networks being more heavily involved and taking a more population-based approach to our healthcare. We have an academic health science centre concept where we want to really embed research and education within our health services. And I was just mentioning to Linnell, the PHN will be becoming an official member shortly with the Academic Health Science Centre. So once again, it's all about that partnership. And I think the thing that's on everyone's working towards at the moment across the world is integrated care. And that's where I really see health pathways being a really key piece. Integrated care for me is really about how do we improve communication so people are actually going to the right place. So today is really that start point for us to start looking at how can we get people that are out in the community, people that are in the acute hospital sector, people that are in mental health, drug and alcohol, people that are working in community-based services within the LHD. I think there's a lot of good work individuals are doing and a lot of effort, but we can start bringing it together so we get much better outcomes.
From the PHN's side, we opened officially on the 1st of July, so we've only really been going for 9 months now. The first few months really were the board and in discussions agreeing what the vision and the strategic priority areas will be for the Sydney North Health Network going forwards over the next 3 years. And we had our big launch in December, and I know that a lot of you attended, so thank you so much for that. And really our key priority areas from that process were building capacity in primary health care as our first priority and need to really be able to strengthen the primary healthcare system as a whole. On top of that, we have service transformation to start to actually transform services across the system. And in that element, we've got Health Pathways as one of our key priority areas that we can work in partnership and together to actually start to not only support clinical decision making on the ground and access to what services are available locally, but also to actually make that next step to utilise the bringing everyone around the table to decide and agree service changes or different ways of working or fast track referral process. I mean, the options are endless. That this is the start of a journey that we can really work towards really real service transformation, which I know we hear a lot, but wouldn't it be wonderful to start to see a difference in the services that we provide together across the system. And lastly, the other two priorities, not lastly or leastly, David, sorry, is commissioning, which is a key element of what we're doing, and we've got key focuses around mental health and drug and alcohol in the first year, over the next year. But the reality is everything that we do, we want to have health pathways as a key part of that to enable, collective decision making and ensuring that we are creating the right pathways across the system. So it's a real journey for us, and we see it as a PHN as a real key priority area for us going forwards. And of course, finally, our fourth strategic priority area is the organisational excellence, and it's to ensure that we have the capacity and the ability to be able to commission well, to be able to actually deliver on what we say and what we commit to, including health pathways, and that's a really important part of the organisation. Thanks.
So we really want to go from a system where, as I said earlier, I think a lot of people are working really hard and are getting good outcomes in isolation, but the opportunity to actually move to a more coordinated system where people know what's going on in the relevant sectors and know who to approach, that's really where we want to get to. And I think this slide's important. If you look at the bottom where it talks about integrated health and social services, I really see us in the next couple of years focusing on the health component. But I think when we get that right, we should be really expanding, like a lot of other countries have, into education, more social service type areas that have significant impacts upon the determinants of health of our population.
So finally, as a collective local health district and primary health network, we really want to present this as our joint program going forwards, and I know that many of you will have seen the triple aim that's come out of the US around patient-centred medical home and different elements. Well, there is the concept that's growing, which is, I think, extremely important, the quadruple aim, and it's really saying that to really achieve better health, better care, and better value, we actually need to also be supporting the people that are providing the services and linking the system together to enable that to work, so that we don't have burnout of the practitioners. It's not just about working harder in general practice or working harder in the hospital to pump people through. It's actually about how do we work more strategically and together and support the people that are providing the services to really make a difference. And I think that's why we're all here today, and good luck with the journey, and I look forward to working with you as we go forwards. Thanks. So I'd love to hand over now to the experts. Who's starting? Sorry. Thank you. I'll let you introduce.
Thank you. Good morning, everybody. My name's Andy Froggatt. I have various titles, as I found out a few other people have in this room, but for today I'm sort of the Chief Advisor for Health Pathways, working with Streamliners. We're very, very pleased to be here today. You're the 28th place now that's taken on Health Pathways across Australia, New Zealand, and now in the United Kingdom. So it's a growing community of people, which is in many ways one of its strengths, because the ability to share all of this work and information is a great assistance in setting up and getting on the journey that you're going on. I might like just to start by introducing some of the team who are here from Streamliners. I'm the token UK-Australian bloke. The rest of them have come over the ditch. So firstly, Dr. Graham McGeoch, who will be the main focus of today. Graham is really kind of in many ways the sort of originator of Health Pathways, going back to when Canterbury were having many of the conversations that your colleagues have just been talking around then. Also in the room I've got Matt Sinclair across here. Matt's our, what are you, Matt? Our Service Development Manager. Thank you. I can never remember titles, I'm hopeless. We're very lucky to have Matt here today, seeing as he nearly didn't get here because he left his passport at home and missed his flight yesterday. Yeah, I thought you would be, yes. And at the back of the room, if they can just stand up, because they'll be out at the front in a little while, we've got Jenna Pankhurst, who's the lead regional writer, who will be a really key contact with some of your people who are developing Health Pathways. And the person who leads the whole writing team is Melissa Taylor, who's at the back there as well. So those guys will be contributing a little bit later on today, and particularly in tomorrow's sessions, where we get to work with your team around the nitty-gritty of how all this stuff works. So thank you from all of us for having us here today. I think I have to do the toilet stuff and everything, so if you've not managed to work that out yourselves yet, the toilets are just down that way. And if there's a fire or anything, sort of run that way and you'll be fine, or so I'm told. Just a little bit about myself as well, and how I came around to being involved with the Streamliners team. My background is sort of varied, mainly I think because I have a fairly low boredom threshold, but I've been involved in running acute services, also working in primary healthcare organisations and running NGOs as well. So I've always had a particular interest in these issues of how we actually manage to integrate services and systems, and how we move beyond what are often great initiatives but that tend to be driven by individuals to ones that actually can be done at a level, at this system level, that actually have this constant impact and constant ability to improve and change. And I came around Health Pathways originally as a customer. So we were the first people to implement Health Pathways in Queensland, up in Townsville, which is where I'm based. So whilst the team here have been involved in this for a long, long time from the NZ perspective, I've actually been somebody who's also seen it from the other way of being a customer of the team, and decided they were all actually rather quite good and it might be good to work for them for a while as well. So I can give some insights from that side of what it's like to be in your shoes starting this journey from yourselves. And later on today, we'll have some of your colleagues from another Sydney jurisdiction who'll be able to take you through what their experience has been in a region close to you around developing Health Pathways, what works, what doesn't work, what some of the opportunities are, and they'll be talking a little later this morning. I think Graham later on will talk around the Canterbury journey in a great deal of depth and with a great deal more knowledge than I, but I think some of the stuff that's just being talked about there by Lynelle and Andrew are really the same questions that were being asked in Canterbury all of those years ago, and are the same questions that are being asked whether we're in the United Kingdom, in Singapore, in Australia. The conversation is exactly the same. The issues are exactly the same. The question is, how do we do something that actually may work and may impact on those things in the long term? And I think that's why people have looked at things like Health Pathways as being something that people can make sense of, and that they can see as an enabler for some of the changes that you may want to be able to make in your health system. And in particular then, I think Lynelle talked around transformation. How do you then take this concept of Health Pathways and link it to some of this redesign work that you're wanting to do in your system so it has impact? So Graham will take you on that journey, and he will also show you some of the impact that's actually made at the system level in Canterbury. When I first went to Canterbury and heard all about this, I thought this was fantastic, and I dreaded going there and thinking it was all smoke and mirrors. Fortunately it wasn't, so I was rather pleased with that, and hence here we are today. I think the other thing that's very important to say is that when you look at the work that's been done in Canterbury, whilst it is, I think, incredibly impressive to see, in many ways there's nothing unique about what they've done. There's no great magic formula. There is no sort of guru sitting behind this who's thought of concepts that nobody else has thought of before. Most places have worked on pathways in some form or other. People have dabbled in acute demand management. They've worked around falls programs, all sorts of things. But I think what Canterbury have managed to do is A, they've done some of those components very well, but they've managed to put things in place that say, well, how do we actually manage to have these conversations as a whole of system? And how then do we actually have a way of being able to say, this is how we want to go about changing this is how we do it, and this is actually how we actually allow people to access that information so that they can actually work as one system. And I think that's the thing that I found incredibly impressive about the work that they've done. So there's no magic that they've got. You've got lots of this stuff, you know how to do lots of these things, and we learn lots from people like yourselves. But I think the way they've put that together is the key to the work that they've managed to do, and I think that's the thing that actually that's particularly impressive. I might just give a quick example. We're working with our first customer in the United Kingdom in South Tyneside, and they're looking at Health Pathways, but also doing some wider system transformation stuff. And just a little example that occurred there that to me, whilst it's funny, kind of sums up sometimes how we're not very good at doing this stuff. I was at a meeting with about 80, an education session with about 80 GPs, and I think Graham had attended one previously. And the session was around some cardiology education. We had 4 cardiologists there, 2 from a hospital in South Tyneside, 2 from Sunderland City Hospitals. And they'd come along to talk the GPs through some tricky cardiac stuff, show them the pathways that they'd done for them. So they appeared at this group of 80 GPs to present the pathways that they had written for the general practitioners, faux pas number 1, which they'd not rumbled. And I have to say, these were very committed guys who'd clearly put an awful amount of work into this. They'd done it for all the right reasons. Gave some very good clinical stuff that went down very well. And then one of the cardiologists said, and of course we sent you these pathways a year ago, and I could see the GPs, and there was 80 blank faces in that room. None of them had seen any of these pathways. So that was pretty bad. Then at this point, somebody actually stood up in the middle of the room and said, well, actually, no, we didn't, because we couldn't agree who would pay for the lamination on those. Now, if you think about that, whilst it's funny, that's not untypical of what we find ourselves doing. So we've actually had, through no lack of commitment and no lack of energy, a whole bunch of work that's actually been wasted at a whole bunch of points, and for a year nobody's had access to what probably were quite good pathways, and would have even been better if they'd been written with GPs who actually know the questions they need to ask, because it's a different issue from what they have in a consultation to a full-on clinical pathway. Now the great thing from that is the first people on board with us in South Tyneside are the cardiologists, because we can say to them, A, we would have saved you a load of time in developing these, B, they would have been written from the GP perspective, which is what we're doing, and C, people would have had access to them for the last year. So it's a very simple thing in many ways of what we're trying to do with Health Pathways, and its great strength is that the process that develops those pathways, whether we're looking at atrial fibrillation, depression, dealing with frail elderly people, the process is the same. It's just the content that is different, but you get this consistent thing that everybody can access, and it's about your local health system. It's not about somebody else's, it's about yours. And that's a key thing here, that Canterbury may be a starting point, but what you do is about your health system and how you want that to look. And that's the exciting bit of it, and I think that's why people buy into it, because it's theirs and they develop it. So, you're as I say, the 28th group of people coming on. We now cover over 20 million people are in regions now that have developed health pathways. So it's becoming a very large community, and there's more and more things that we're trying to lever from that community to provide things that are useful to our community members. And I think that as you start your journey, some of the stuff that I think is particularly important, and I think that you covered that off really well, is that where this fails is where you don't have that buy-in from people, where you don't have people engaged, not just at the senior level, but through your systems, where people see that this is some project that will be here again and gone in a year. The key to this is that you've made an agreement and a decision that this becomes business as usual. It's how you do your work in North Sydney. And one of the great things for people was when we moved from Medicare locals to PHNs, the first thing we heard was, is this going to disappear with that move? And it hasn't disappeared anywhere. In fact, it's continued to grow and develop because it's not dependent on who's running the show. It's actually about how we create relationships and a process that develops this body of work. And I think that's one of its great strengths as you move forward on this journey. So, programme for today, it's very straightforward. It's mainly Graham, really, when it boils down to it. But the programme for today really is around giving people who've maybe not had much access to this a bit more of an overview of what this is. So what we'll be hearing from for most of this morning is Graham's going to give people a quick drive through Health Pathways, how it looks, how it's used from a GP perspective. And then after our morning tea, what Graham is going to do is take you through some of that Canterbury journey, how it started, some of the things that have worked, not worked, and really what's actually happened over the last eight, 9 years of the Canterbury journey. And again, I think, some of the data that Andrew was showing there, if you want to start impacting this at a system level, what are some of the things that have happened in Canterbury to be able to start changing some of those indicators? It's not a panacea for all your woes, but it's something to help you be able to manage some of those things in a much more efficient manner and provide better care for your people out there in the community. Later on in the morning, Jenna, across there, and this will be her first presentation, so she may be a little nervous, so be kind to her. What Jenna will be doing is just giving you a quick overview of what sits behind Health Pathways. So whilst people, in terms of this, will ostensibly see the sites that what Graham will show you, what sits behind it is a whole bunch of content management support, so that when you're developing pathways, you're not running Excel spreadsheets, Microsoft Outlook, etc. It's a very efficient way of managing information, making sure you communicate that effectively to your clinicians who are involved in that. So she'll just give you a quick overview of that, and she'll do that in a lot more detail tomorrow with your Health Pathways crew. And then in the afternoon, we'll have Paul and his team talking to them about their experience in Sydney, before we just finish off with a final half an hour where I think Fiona, where are you, Fiona? I've lost you. There you are. Well, where I think Fiona, who found out about this about 10 minutes ago, will be just talking through with you in terms of where the team are at, what they've developed, and how this is going to move forward in your local region, which they're quite on top of, so don't worry about that. They know what they're doing. So we hope you really enjoy the day. We like it to be pretty interactive, so feel free to throw questions. What I will ask you is, you can see at the back we have a gentleman who's videoing the session. Is your official title videographer? Excellent. So one of the things we watch, we do have a couple of roving microphones, so if you have a question, could you stick your hand up and wait for the microphone to get to you, because otherwise we won't be able to hear the question on the video, and there's a number of people expressed an interest to be able to see some of the sessions, so if you could just be a little patient with us, that would be very much appreciated. All right, so have a great day. Lots of interaction, lots of conversations, and I'm going to hand over to Dr. Graham McGeoch. Over to you, Graham.
Well, good morning everybody, and thank you very much for having us. You'd think after we'd done 28 of these I'd be quite good at it, but I'm actually really a general practitioner, so when you can't understand what I'm talking about, I'm more than happy to take questions as we go through. So the first bit of this is me showing you what we're doing and what Health Pathways is actually about. So this is going to be your Health Pathways site in Sydney North. So it actually exists, but it's not going to be put out live to the health community until you've got some local content. So at the moment this is virtually a rebranded version of the Canterbury site, and then over the next while, hopefully within 3 years, you'll have everything localized. You will go through and change all the stuff you don't like about what we do in New Zealand to Australian stuff, and also put all your local services and local ways of doing things. Who's going to do what where? And that's the negotiation, that's the redesign as you work out who's going to do what. So if you look down the left-hand side, you'll see there's a table of contents which really reads like a medical student's list of runs as they get trained, and is also really the division of many hospital departments. And that developed not for any particularly good reason, but simply because we learned very quickly that gynecologists aren't interested in orthopedics, so you have to run this from a departmental perspective. And it grew from the bottom up as we visited each department and put down their agreements with general practice and the community about how we were going to look after these groups of patients. We grew the table of contents. Now up the top, before I always forget to talk about this, we have a send feedback button. Now that's the same as every other website has a send feedback button or a contact us button. So we put one on because we thought it was the trendy thing to do. But actually it's proved to be invaluable. What's happened is we've got a very rich and frequent conversations between general practitioners, practice nurses, rural people, Maori health workers, who send some feedback in and saying we don't do that here. We do it like this, or that bit's wrong. I read this article and we actually do it like this. Or the cardiologists in the pathway say they're going to see patients when they've got this problem and they've not seen this patient. Actually, what's the problem? And all those things we respond to and very actively go back and make sure that these agreements are actually followed. The triages of referrals have to, they've agreed to see them urgently, they better do it because they've said they're going to do it. General practice expects that. So that send feedback button has been great. It also means if we pitch the pathway at the wrong level, we can make some corrections if people can't understand it or they think things are missing or too complicated. So these are the sort of things we've been working on. Youth health, for some reason we've reviewed constipation in children, which is actually a really important pathway and has meant that virtually no children without except the major problems end up in child health services because they follow a set script on health pathways. We've written a diverticular disease pathway. We've added a new test to hematuria, which is a sort of New Zealand invention. And then we use this for health system news. So I don't know here, but we get a lot of public health notifications about measles and Zika virus and all sorts of other stuff. And GPs get them on bits of paper or ignore them. We stick them all in here very quickly, completely up to date. GPs open this in the morning, have a quick glance, and it's there for them. You can see the most frequently used pathways here, which some people use as a way of accessing them. So that's the home page. Now, if we look at how it's actually used, so in New Zealand now it's 20 to 2. No, it's not. It's 20 to 12. I haven't changed my watch. So it's 20 to 12, so right in the middle of morning consultation session, and there are 34 users on the site. So it's a password protected site. This is only Canterbury, nowhere else. And so there's 34 people using it. They're looking at herpes zoster, miscarriage, gallstones, recent sexual assault, oh dear, insulin regimen, subfertility, influenza, and you can see they're moving in and out all the time. So a lot of these will be general practitioners, some will be practice nurses. It's used in the hospital a lot because the house surgeons and junior doctors are on the wards. There are patients who come in and they have problems that are actually usually dealt with in the community, but they happen to have them in the hospital. They use health pathways a lot. It's used a lot for teaching medical students, GP registrars, other registrars. It's used a lot by allied health.
You say 36, it sounds like a very small number. How many primary healthcare providers do you have in this Canterbury?
We've got about 500 GPs, the same number of practice nurses. That doesn't mean they've got the site open. They're actually clicking pages at one point.
That means 0.35%.
This isn't per day, this is right now. This is at this instant, within the last minute, there have been 35 people using it.
Can you show us some data on the last 24 hours or the last week?
I could do, but we'll do that at tea time or something. I can show you more analytics later. So, each pathway, I thought I'd show you bronchiectasis for no particularly good reason, but it's a fairly general condition that general practitioners have to deal with on an occasional basis. Now you see this is prominently labelled as non-localised New Zealand content on your site. So the fastest you can get rid of that, the better. On the whole, what we found is that clinicians are quite happy with the majority of the clinical content in health pathways, but when you get down to the request section, when you're asking for a respiratory physician, we don't want referrals to our respiratory physicians from Sydney, so it's obviously of lesser benefit, although it can point out about where you could, when to make a referral. We have an about section which just covers very briefly the basics. When we wrote this pathway between with a general practitioner and a respiratory physician, the respiratory physician had volumes on bronchiectasis. It's a special interest, and was very disappointed when we cut it down to one page. As a GP, I don't know all that's in here. I have to look some of it up. As an experienced GP, what I'll be doing is flicking down and seeing maybe what are the tests that I should be doing for this person, what other interventions can I do. So we very much at the top of the management section link to other things, allied health responses, non-governmental organisations, the things that in general practice it's really easy to forget. What are the right vaccinations to do for someone with bronchiectasis, because they need a pneumococcal vaccine and a flu vaccine and all that sort of stuff. How you get those. Homes and heating, there are various social supports that can be provided for people who have poor quality uninsulated homes, which is quite a lot of homes in New Zealand. Smoking cessation, pulmonary rehab. So the other stuff other than the pills, which is what GPs may often remember. And then when to get specialist assessment. Not all patients with bronchiectasis need to be under specialist care all the time, but when is it that our respiratory physicians would like to see these people, which may be different from when your respiratory physicians want to see them, because you may well have more respiratory physicians per 100,000 than we have. Whether they're doing the right things is another matter. They may well be seeing patients of lower acuity who could be well discharged back into general practice follow-up and care, and be seeing the patients who general practitioners are worried about, who meet these access criteria. So that is how you can use this to unclog your outpatient clinics. If, like everywhere else in Australia we've been, you have long waits for certain outpatient clinics. There's a few nodding heads. So that's a fairly straightforward medical pathway. The next one I wanted to show you is cognitive impairment, which is really one of the long-term disorders that you can almost put as the incidence goes up with diabetes and COPD, which tend to be much more complicated. Practice points are a new feature that weren't in the other one, which just points out some critical pieces of information that the authors thought would be worth doing, that might be a change in practice. So maybe 10 years ago, the majority of patients in Canterbury with a new diagnosis of cognitive impairment would go to the memory clinic, and the specialist psychogeriatricians would work them up and then discharge them back to general practice. And that became the in thing to do, but rapidly they became overwhelmed, had far too long waiting lists and couldn't manage, and we sat down with them with a work group of general practitioners and other people from the community interested in this area, and worked out what we were going to do, and that became this pathway. So greater involvement of a wider group of clinicians than the secondary care memory clinic in the care of people with cognitive impairment. Now again, as an experienced general practitioner, I'll go straight in and I won't read it from top to bottom. I'll be in a consultation with a patient and I'll print out the short IQ code to give to them for the family to fill in. I'll get them back again later and I'll want the MOCA or the MMMS and a clock drawing test, and then I'll want to know which patients I should refer and where or what management I should do. So again, you'll see a strong element of the medical services in here, so linked to the dementia support services, how to manage carer stress, how to antipsychotics in dementia is a sort of changing area. We used to use them, they're actually really bad and you have to be very careful, so we have that all written in carefully. We look at driving, end of life, financial, legal, care plans, so it covers a wide range of the things that people want. Very easy to find while you're in a consultation with a patient. If you're a less experienced general practitioner or you're from another profession, you might go down more systematically from the top to the bottom. And again, in the request section, we've laid out clearly which patients end up in specialist services. And that has had marked, and we have got data on the changes that produces. So we have general practice and the community, the dementia support services, Alzheimer's New Zealand, are very pleased that they're getting a lot more referrals from general practice than they ever used to get. The hospital services say they're getting the more complex patients, the younger patients, and they think that's an appropriate shift, although they complain all the patients are difficult and they all turn up because they're sick, so they don't get a tea break. So that's been a serious impact. General practice complains they have to do more before they can get their patients seen in secondary care services. So this does have quite an impact, and you have to work that through with all areas of health professionals that you're working with. Allied health, we discovered, were not particularly systematic or organised. They tended to be arranged around a hospital department, and when they started getting referrals from general practitioners meeting certain criteria, they found that quite hard. So we've done a lot of work with Allied Health to work out how we can make best use of them in our health system, and that's gone really well. Down the bottom, you'll see we have wait times in there, trying to make them a little more explicit, and we your health system is a little less clean than ours between public and private, and so a lot of private patients seem to be, a lot of public patients seem to be seen in the private sector, but ours is much cleaner. If you go privately, you pay the whole lot, you get no subsidies. If you go to the public system, it's fully subsidised in hospital and partially subsidised in general practice. So we strongly encourage people to go to the private sector when they can afford it, because that allows us to manage the demand. So we clearly we talk with our private practitioners and get their details on here as well. In the clinical resources section, this is mainly for further reading and education. So our GP college has an arrangement with BMJ Learning for their learning modules, and you can put in all the excellent Australian resources for education of general practitioners when they realise that they haven't seen a patient with bronchiectasis for about 10 years, and they can go away and read up about it afterwards and go to a good source fairly quickly. Linking to patient information is very important for us, and we have our own local website called Health Info, and then we link to other things from Alzheimer's New Zealand, Alzheimer's Australia, patient.co.uk. So we link to what we think is the best, and unashamedly link and copy from everybody else around the place if they've got the best stuff. We reference the base guideline that the pathway is broadly consistent with, and then we reference selected things that are new or contentious, is generally what we do. It isn't a duplicate. HealthPathways is not a duplicate of up-to-date or evidence-based guidelines. It's how you do it around here. So it is a different thing. And then if we've done any quality assurance work on clinical audit work on an area, we put it on the bottom of the pathway to show people whether the pathway is actually working. So we try to look at that at times. We do use flow charts, which won't look particularly good on this because of the screen layout, but we do use them for the small number of people who actually like flow charts. We find about 10% of people are flowchart enthusiasts and algorithm users, and about 90% of our users, because they're dipping in and out looking for a specific piece of information, can find it in the very consistent layout of Health Pathways. Everything about management is in management. They can find it more easily there than in an algorithm-based system. It's a frequent cause of debate in Health Pathways because people think they want lots of flowcharts. Other areas to talk about. How am I doing for time?
10 minutes to go. You want to as well, Graham, at some point just talk around, for example, if in North Sydney here they were looking at developing a cognitive impairment, just an outline of what that process would be like for them, who's engaged in that. If your services for cognitive impairment are going fairly well and you don't need to redesign them because actually what's happening now is quite adequate, then you need a clinical editor, which is a general practitioner, and they will talk more about that later, and a subject matter expert who would be somebody delegated by a hospital department, and that can be a cause of some negotiation, to work with the clinical editor to write the first draft of the pathway adapted from the Canterbury one, or you've got access to all 28 varieties of the cognitive impairment pathway from all the other regions. And just because it's Australian doesn't mean it's better, because a lot of the Australian sites are in their infancy and some of their pathways are very long and complex. So the clinical editors have a look through, work out which is the best, and base their new draft on that best one, because there are some, we've been copying the Tasmanian palliative care pathways, for example, in Canterbury, and the diabetes pathways have been through about 6 different cycles, and you can kind of follow them through where people have rearranged it all, which is great as we all learn from each other across all the expert health systems in Australia and New Zealand. Is that what you meant? Jolly good. So once they've got a draft up, you then circulate it using the Health Pathways. There is a system for doing this. Circulate it for wider review. So it might go out to all the interested stakeholders, including community groups, as you see fit. Have a look, have input into, and see if that's what they like. So this is for something that you're not going to redesign. If you think actually your services for cognitive impairment need a bit of work, then that's where we sit everybody down with a work group and negotiate how we're going to do it differently in the future, which is a lot more elaborate, a lot more work. Each one is a project or a series of projects, and so those have to be prioritized by the powers that be and done in some kind of order. You can't redesign everything all at one go. Other sections we've got in here that are worth having a look at, which still has, it says our health system, but it's actually the Canterbury health system. So we put in here, what's happening here? Oh no, here we go. So this is really good for orientation. I'm sure you have a number of New Zealand wanderers and UK wanderers and GPs from multiple countries who arrive in
Sydney. And when they arrive, they will have a hazy idea. They'll have some orientation, most of which will go in one ear and out the other. And when they actually have to deal with the funding and things, it's really good to put in here how your funding system works in a way which is done once and not 10 times. It's very difficult for practices to maintain this level of information to orientate their GPs. So this is widely used for orientation under those headings. It's amazing the places when we've tried to document that, we've actually found that nobody else was clear about it either. So that when you came to write it down, you actually ended up doing a bit of redesign and improvement on the way that things worked. Good.
Could you as well talk, one of the things when I first went to Canterbury that struck me is in terms of the way that they ran their education forums and its relationship to Health Pathways. Maybe we just want to cover off on how Health Pathways and the education work you do between specialists and GPs functions there as well?
So we have had since the days of IPAs, independent practitioner associations, which were vaguely similar to either your divisions or I think more the divisions than anything else. So we have had a small group education program run by Pegasus Health, initially for GPs, now for GPs, practice nurses, district nurses, other community nurses and pharmacists. And it has a two-way relationship with Health Pathways. So when they run an education session, we will incorporate their information in Health Pathways as appropriate. And then when we develop a pathway, we also have education sessions, and we usually get between 80 and 120 of our 500 general practitioners coming along, so not all of them, and inform them about the pathways, have usually specialists, hospital specialists or staff, and nurses, doctors, allied health from the community jointly presenting to the audience, because we find that a really good message, that this isn't the hospital imposing on general practice, it's a joint thing, and those are very well appreciated. They're at different levels. The Pegasus education tends to be higher professional education, make you think stuff. Ours is more, this is process information, how do you actually manage this changed pathway. So there are different focuses of education, and we try to use multiple forms of communication because myself and my colleagues are very difficult to communicate with. We love the waste paper basket for anything on paper, and we don't read email, and we're actually a pretty difficult bunch, so we use multiple communication to try and hit people at least once with messages that we want to get across to them. And the whole point of this and where the idea came from was me having multiple filing systems over many years to keep all the brilliant information that I got and the wonderful guidelines I was sent in CDs and folders and pieces of paper, and from education meeting I would file them away in a filing system that seemed brilliant at the time, but then when I actually wanted to retrieve that piece of information when a patient turned up a year later, and I thought, oh, well, I'm sure I learned something about that, I couldn't find it. So the idea of this is that it's a filing cabinet of the information that is needed for general practitioners and other colleagues, because the way I've described it before is we've been flying a jumbo jet for patients without a manual, and you wouldn't do that in the airline industry, and we shouldn't have been doing it in health. So we're trying to provide that manual so that we can at least work a little more consistently than previously.
And Graham, one of the questions, so I'm feeling like Tony Jones out the front here. Just one question I'll hand over to. In terms of the other question that often comes up as well, in terms of then maintaining currency of pathways and reviewing those, could you just take people through how that operates?
So any errors or broken things get fixed immediately. We found a typo at breakfast, and they never have typos with streamliners, but we did find one, and Melissa corrected it then and there. So it's highly responsive. It's not fixed at all. So just because something's gone live on the website, we then make regular daily partial updates. So if something changes, because things are always changing in health, so access to medications changes frequently, so we would change that, communicate it between the subject matter expert and the GP clinical editor, make sure everybody agrees, get it signed off often by a third person, so we have a community pharmacist who works with us, and so we make these partial updates on a daily basis to make sure that things current, and then we have a 3-year review cycle, which is actually very hard work. We're working out how to do that on an efficient basis, hopefully sharing the work of the academic review across many health districts, which is why we're so pleased to have you guys on board, because you can put some academic rigour into reviewing the pathways with us every 3 years to make sure that we keep it up to date. People say it takes 15 years to get evidence into practice from the BMJ to my desktop, which I can well believe when you look at things like beta blockers in heart failure, ACE inhibitors for diabetes, other things that should have been pretty simple for us to change, but it literally took that long to get those changes widespread. So evidence into practice more quickly, because it's easy, it's on people's desktop, they know they can trust it because it's been developed with their local colleagues that they know, refer to and trust, and hopefully reduce some of the unjustifiable variation that occurs in even the basics. So those reviews are most important. So partial updates as required, and a regular 3-yearly review cycle. We tried 3, but it wore us out. We tried 2, and 2 was too hard. We couldn't keep up with it, so we've gone to 3. It's your choice what review cycle you do, but as we're going to try to share the load around the community, hopefully over time we'll synchronise the reviews across the different health regions. But you maintain local editorial control over the clinical content. Don't have editorial control over where the commas go. That's in Melissa and Jenna's technical writing thing, and that's a frequent cause of international dispute as to the where the Oxford comma sits and what should have capitals and what shouldn't, and you'll lose every time.
As a customer, I learned that very quickly, that wasn't where I wanted to go.
Martin Carlson, a science director for Northern Sydney Health, and we have lots of protocols and pathways within our hospitals and communities. One of the biggest problems I see is that we don't adhere to these policies and pathways. So I would be really interested in how you implement these pathways and how much data you have on adherence to actually these recommendations.
Yep. I will come back to some of that after morning tea, but as far as having many pathways go, that's one of the problems, and they're often in multiple different places. So in our system we had haematology guidelines that sat on one website. We had New Zealand guidelines, group guidelines that were somewhere else. We had all sorts of things that weren't in one place. It's very difficult in general practice to manage that, especially if they're password protected sites. We get lost, and so we just don't do it. We don't have the time to do that. As far as adherence go, we have, I have a full-time non-clinical doctor working with me doing exactly what you describe on cohorts of patients. Now, obviously, she can only manage a relatively small amount, but she goes, whenever we make a significant change to a pathway, we'll go through a cohort of patients and watch whether the pathway is being followed. From histology results, outpatient attendances, all the common views we can have, we'll look at key stages of the pathway to make sure it's being followed and that it's actually working as designed, and that comes up with a series of recommendations, and we go through a quality improvement cycle and make sure that that's happening. So you can find out, I can put you onto things we've published on community spirometry, which is laboratory quality spirometry put out into the community. We've published on skin cancer excisions using the same thing, but we can't do it on every pathway. There's about 800. We'd love to be able to. Again, that's something, there is an evaluation group of the Health Pathways community that you will need a North Sydney, or you'll be offered the option to have a North Sydney representative on it, and maybe you'd like to volunteer yourself to go on that committee and help work out exactly these questions, because it is very difficult. I mean, we know that there's good evidence that guidelines, standard traditional guidelines, don't change practice. Why might this? Well, that's what we've got to find out, exactly what the elements are that mean that this might work and other things haven't. We could talk about that all day, but
Doesn't satisfy me, but
I'm sure.
interested in hearing.
I'm not satisfied that I could say that this always does good, or that it always changes outcomes for the better. I think in the majority of most of the time, it's working in a positive direction. Difficult.
Right, we're nearly at break time. Is there a couple of questions before we break for morning tea? Yep. Oh, thanks, Melissa.
Morning, Jeanette Connolly, Medical Executive, Sydney Adventist Hospital. My question is, does this platform interface with the clinical information system, such as Medical Director? For instance, when you're clicking on the referral, a lot of GPs would have the referral information in their clinical information system, so how do they interface?
When we started doing this, believed that we would be putting this into some smart decision support tool that was linked to electronic referral, so we set it up in that way. Over time, we're not so sure that actually tightly tying them together will work, because the advantage of this is its flexibility and rapid ability to change, whereas when we were writing structured decision support tools and referral forms, you had to get a software developer to make the changes, and we would never have got the relatively comprehensive nature if we had tied them together tightly. So this doesn't lift patient-specific information, individual patient information. What does happen is that we have a parallel electronic referral system that Health Pathways tells you which electronic referral form to use, and then within the electronic referral form it has a summary of the information required, and also on that page there is a link back to the right page on Health Pathways, and there are ways that we can do that with Medical Director, although some of them may charge you an exorbitant amount of money to make the links between their system and Health Pathways. But Health Pathways is just a website, it's no more complicated than that, so it can be linked from any other electronic referral system.
We're very careful not to get it tied up in development paths that end up with it failing. And as Graham said, I can't remember the figure now, but with Medical Director right now, it's possible, but it's an exorbitant amount of money that they want for for every single user, which nobody would pay for at the moment.
And we found that referrers around different districts are reasonably happy to look up the information and then use their professional skills to write a good letter with a memory jogger to put the right information in. So we had quite a lot of structured referral forms for gynecology particularly, and the referrers chose not to use them. So they would have a condition, ovarian cysts or heavy menstrual bleeding, that had a structured form, but they would just send a generic gynecology referral, but with the right information from Health Pathways in the referral, rather than ticking the boxes. And as Andy said, we developed this very practically for our own use, and if the GPs weren't using it, we went down another route. I hope one day we'll have artificial intelligence tools that will link the pathway to the electronic referral and guide things, but we're just not there yet. Sir, you got a question? Yeah.
Hi, I'm Reza. I'm Reza from DY Pharmacy. My question, you've already answered this, but I just want to clarify with the review of the content, the clinical content. Was it part of the 3-year review or consistent content update? And where do you make the choice of when to update the content? Is it based on consensus from the review panel that you have, or you wait for a certain time for the practice to change, etc., etc.? How do you decide on when you're going to update the content?
So the review process is a general practitioner clinical editor run through the subject matter experts, so that who's usually medical but not always, and a community pharmacy review, and then we circulate again the interested people in our health system to see if they have comments. So that's the depth of the review that we make at the moment. Is this still working in our health system? Does it still appear to be a reflection of evidence-informed practice? And does it read okay? Because when you first localise the pathways, there'll be a lot of politics and people will insist on putting stuff in. And but when you look at the key audience, and 3 years later, a lot of that tension and angst will have disappeared. You can get rid of all the extraneous stuff that the key audience really doesn't need, and make it into back to a practical tool from being a reflection of people wanting to make sure their opinions are reflected. So it's very very flexible process, really.
I'll just do all the work, Melissa.
Thanks. Hi, I'm Stephen Clark, I'm a medical oncologist in Sydney. Can you tell us what sort of outcomes has this changed? You've got a vastly different healthcare system to us, where not everyone can access GPs because they don't want to pay and turn up in public hospitals and stuff. And you've got a vastly different pharmac system to us, where a lot of drugs aren't approved. So how do you incorporate all those kind of issues into your system? If you go to a public hospital, do those patients get treated along the same lines as this? How do you adjust for, we have a lot more drugs available than you do? And what are your outcomes in terms of changing practice, changing survival, changing all those sort of outcomes that we have in cancer, for instance?
Well, again, I'll show you some graphs after morning tea of some of the impacts that it is having in our health system. This is obviously only a small part of our cancer strategy, but it is one where, for general practice particularly, I think that's where we inform general practice of the way that they should and could be managing cancer. That's where they go and look. So if there are messages to get out in changes of access to diagnostic investigations or follow-up protocols, then that's the place to put them. Obviously, there's a great deal of work needs to be done. I can't point to I can't say that cancer care in Canterbury has improved because of Health Pathways. I just can't do that because of attribution versus contribution. It may have a small part, but so does all the joint work we've done with all the oncologists and surgeons and physicians as well. We are looking at our melanoma follow-up rates, for example, because our plastic surgeons were under a lot of pressure with skin cancer generally, and one of the things we said was we can follow up the patients with non-metastatic, non-advanced melanoma in general practice following the Australasian guidelines. So we documented that carefully in Health Pathways, developed patient information leaflets, got brochures for the plastic surgeons to do. Now we're auditing whether those patients have had the follow-up that was agreed, and have there been any adverse consequences. And the initial results are, as you would expect, not all the patients have had the follow-up that they should have had. And so we're tracking down, is that because they weren't well enough informed at the beginning? Is it because patients are patients and just don't do it? Or is it because they don't believe that general practitioner follow-up is good enough? What's exactly happening? So we do use this as a baseline to then be able to do those monitoring exercises and quality improvement cycle. We just cannot do it on every single condition though.
All right. What we might do is just break for morning tea, and then I think there's a few of those questions Graham will be covering off some of that information in a little bit more detail as well in the next session, and then there'll be further chance for any follow-up questions as well then. So if we can take about 15 minutes. What time is it now? No idea what time it is.
10:16.
16. If we can come back around 25 to, that would be fantastic. Thank you, everybody.
We have.